Good afternoon, and thank you for joining us here at the ASPEN 21 Central Stage for a session sponsored by Central Admixture Pharmacy Services, CAPS. My name is Joe Bellata, and as the chair of ASPEN's Parenteral Nutrition Safety Committee, I am especially pleased to introduce this topic and our speakers to you today, all of whom are close colleagues and friends. The presentation is based on a significant paper. It was a recently published study on the value of the pharmacist's review of a PN order, a critically important safety step in the PN process. Our speakers were the lead authors on this work, so let me introduce them to you from left to right. Ann Tucker is a clinical pharmacy specialist at the MD Anderson Cancer Center in Houston. She received her BS in chemistry from the University of Arkansas and her PharmD from the University of Arkansas for Medical Sciences, where she also completed residency training. Ann has over 20 years of experience in critical care and nutrition support practice and participates in didactic and experiential training of students and postgraduate trainees. Her areas of interest include fluid and electrolyte disorders, nutrition support in critically ill cancer patients, and the promotion of safe parenteral nutrition practices. She continues to be very active in ASPEN, currently on the board of directors, and previously served as chair of multiple committees. Ann was most recently involved as an editor and author of the ASPEN Fluid Electrolytes and Acid-Base Disorders Handbook. She's a regular presenter for ASPEN events and did a masterful job once again as moderator of the VARS Award Premier Paper Session just this morning. Second, Michael Kraft is a clinical professor at the University of Michigan College of Pharmacy and Assistant Director of Education and Professional Development in the Department of Pharmacy Services at Michigan Medicine. He earned his Doctor of Pharmacy degree from the University of Michigan and then completed a specialty residency in critical care and nutrition support at the University of Tennessee at Memphis, before returning to the University of Michigan, where he has been now for over 20 years. Dr. Kraft has authored over 40 peer-reviewed articles and book chapters, and he regularly makes presentations at local, regional, and national conferences. He's an active leader in several professional associations, including ASPEN, where he has been recognized by his colleagues with several awards and recognitions for his efforts, and has recently been elected, just this year, as a fellow of ASPEN. And last but not least, Sharon Durfee is the National Clinical Nutrition Support Pharmacist for CAPS. She has many years of experience in hospital pharmacy and as a director of a home infusion pharmacy, providing IV services to home care, ambulatory care, and long-term care patients. Sharon has been a longtime member of the Board of Pharmacy Specialties, both on the Nutrition Support Specialty Council, as well as on the BPS Board of Directors, where she served one of her terms as chair of the board. She's currently serving on the Compounded Sterile Preparation Specialty Council. Sharon has also been very active in ASPEN for many years, participating on various committees and task forces, publications, and received the Distinguished Nutrition Support Pharmacist Award. And also this year has been elected as a fellow of ASPEN. So with that, let me now turn the program over to our speakers. Dr. Kraft.
Thank you very much, Dr. Bellata. I really appreciate it. Good afternoon to all of you who are in the U.S. and similar time zones. To those of you who may be joining from outside of that, good day to you, and thank you for being here. Appreciate all of your attention and a chance to talk about our study. And I really want to thank Ann and Sharon in particular, as well as the entire team with CAPS and all the pharmacists with the CAPS team who really made this study possible and kept me on track, which is no small task in and of itself. So without further ado, we will jump into the presentation. I'll start out with a little bit of background for everyone. Before we begin, just our disclosures to note that, well, I am not personally a customer of CAPS, but the institution where I work is a customer of CAPS. Sharon is an employee of CAPS, and Ann has no disclosures to report. All right, to kind of frame this for you, I want to walk you briefly kind of through how this idea came to be, and then we'll get into the details of the study itself. I suspect all of you are aware of the importance of parenteral nutrition and the safety concerns surrounding that therapy. Of course, it's a life-sustaining and life-saving therapy for patients who cannot receive or tolerate oral or enteral nutrition, but it's also a very complex medication therapy. Contains upwards of 30 to 40 individual components depending on the formulation. And of course, the PN use process is very complex with multiple steps, multiple individuals involved, there are multiple disciplines, as well as technologies as well. Of course, it's also associated with significant adverse effects, and there are multiple safety concerns, and we'll highlight some of those here. There definitely has been a significant effort, especially over the past 10 years, to really, reevaluate and improve PN safety. I think a lot of it, while of course there had always been efforts from ASPEN and others, I think a lot of it really kind of renewed, if you will, with the ASPEN PN Safety Summit now 10 years ago. That led to the creation of the PN Safety Committee. And from that, multiple initiatives and papers and guidelines and so forth that have come out, and certainly additional studies that have been published, unrelated even to this committee, but additional data related to PN safety. And so that's kind of where this idea came about, is how can we continue to add to that literature and improve the safety of this therapy. And as you probably know, the PN use process is complex. It's starting with assessing a patient, determining appropriateness. You have to then, of course, prescribe the PN therapy or the PN prescription. That then requires verification and review of that parenteral nutrition order. Of course, then requires products to be procured, and then preparation of that PN order has to be compounded accurately, labeled accurately, and then dispensed, and of course then administered to the patient and monitored. And so multiple steps, it's complex, involves multiple disciplines, and many potential chances for error in this process. And there are definitely a growing body of literature in this area. This study by Gordon Sachs, certainly one of the most well-known and cited studies in this area. He conducted an observational study of inpatient PN orders at an academic medical center, and over almost 5,000 total PN prescriptions, they identified 74 medication errors for a 1.6% error rate. And the most common error that they identified was in the transcription step, that accounted for almost 40% of all of the errors that they identified. And you can see the other errors listed there, but transcription and the manual transcription had been identified as a key source of errors in this process. Then a study by Peggy Gunter and colleagues conducted an evaluation of PN errors or potential errors reported over a 10-year period in a partnership with ISMP, or the Institution for Safe Medication Practices. They reviewed PN-related voluntary reports to the ISMP medication errors reporting system. They identified a total of 48 reports, and you can see here the most common reported was in the compounding or dispensing step. And I think a couple things I note from this. One, as you can see, over a 10-year period, they only identified 48 reports, and I think we all know that medication errors tend to be underreported. And so while this is certainly a valuable contribution, I think many would probably suspect this is definitely an underreporting of the total errors, but certainly does give us an idea of other errors that may be occurring out there that we should be aware of and consider evaluating. The other thing is, if you look at the dates of when this was published compared to when Gordon Sachs did his study, over that time, other things began to advance and improve, in particular the use of technology and electronic health records, and the use of decision support to improve safety. And that, while this study couldn't determine that, it's certainly plausible that some of the use of technology and other things may have led to potentially reducing the potential for errors in some of these steps. Okay. Now, as I mentioned, all the efforts by ASPEN, and in that time, things like the PN safety recommendations were published, and others. Do those make a difference? We had very limited data on the impact that some of those things made. A lot of it was, of course, expert consensus recommendations. And so McKay and colleagues took, I think this is a really nice paper, they took a very comprehensive look at their PN use process. This was a children's hospital, and they formed an interdisciplinary committee to evaluate their process, identify potential error-prone practices. They prioritized and developed and then implemented solutions that include things like technology using computerized prescribe order entry, automated compounding device, clinical decision support with various dosing limits, They eliminated transcription, which I think was notable. And then, they were complying with the ASPEN guidelines and recommendations. When they reviewed their errors over about a 6-year period, as you can see there, the frequency of their errors was about 0.27%. So, noticeably lower than the study from Dr. Sachs. And I think very interestingly, they eliminated transcription errors over that time. And most of their errors, 95% of them occurred during administration. And so that helped to support that one, implementation of some of these best practices can improve the safety, but it doesn't eliminate them. There are some things that apparently can be eliminated. In this case, when they eliminated transcription, but it certainly does not eliminate errors, but does show that there are steps we can take to improve safety. Now, that's I think was a great demonstration of the ability to do that. But how widely are these things adopted? Well, ASPEN and various colleagues within ASPEN have done a few different surveys over the years, including our moderator, Dr. Bellata, who's been involved in these. There was a study in 2003 on parental nutrition, and then led by the Informatics Committee in 2011, then a follow-up survey in 2014. And they asked various questions, particularly related to the PNU's process and the utilization of electronic health records and technology, but other things as well. And I kind of highlight 3 things here. One, I think where we've made really good progress. One where we've made some progress, but have work to do. And I think one area where we definitely have more work to do. And that kind of relates back to the previous slide, where some of those technology solutions can be effective, but only if you're using them. And the one thing that has definitely improved, if you look at the top left in green, the method of ordering parental nutrition, you can see the percent of respondents who reported using handwritten orders has decreased, along with an increase in the use of electronic orders. And in both groups, an increase in the use of standardized, electronic orders in this case, and standardized handwritten orders as well. And so I think that's definitely a good thing that can help improve the process. In the middle, you can see that we've seen some increases in institutions in many areas where they, or maybe stayed the same percentage-wise, that use various steps to limit order entry errors, such as avoiding free text and auto-populating fields and so forth. But we still have work to do there. And then on the bottom right in the red, you can see that a very small percentage actually have automatic electronic interface from their pharmacy system, between their pharmacy system and their EHR, and still a large percentage, require manual entry of those PN orders into the automated compounding device, with only 28% having an automatic interface. So those technology solutions appear to be effective, at least from some data. The problem is we're not necessarily using them effectively or as widespread as we would like to. So with all of this and other discussions we've had with the PN Safety Committee at various meetings, and this idea, it sort of came to me, discussed with some colleagues actually at an ASPEN meeting where I was very, sort of motivated. The idea was, well, how could we capture a larger data set to really get a handle on what PN safety looks like around the country, and what are some of the different tools and recommendations that are being implemented and utilized, and are they effective, at least based on potential errors that are being reported. And so I had the idea for this PN Safety Day, right? It would be a national sort of single day point prevalence study. We could get institutions from around the country to volunteer and participate, to submit on a given day. They would submit, information about their institutions, about their populations they serve, the technology and things that they utilized, and then errors or potential errors that were reported that day. And certainly got some excitement around it, and it seemed like a great idea to be able to get a larger data set and really get a picture of what's going on. And then, of course, reality set in as I got back from the meeting and, get back to our day-to-day lives, and realized all of the complexity of how are we going to sort this out. As I start kind of, thinking through this, we got all the IRBs to deal with. We have to have probably some funding to support it. How are we going to coordinate? Will we need any type of consent? What about security of information and data storage? Is the survey going to be clear? How do we handle that? What about incomplete or missing data? And very quickly I realized I'm, trying to hold up the building here with some 2x4s, and I wasn't quite sure how the heck I was going to get this done, and was really kind of second guessing my own judgment. But As sort of luck would have it, Sharon Durfee and colleagues at CAPS had actually embarked upon a study very similar to what my idea was, and through a conversation there led to the design of this study. So I will turn it over to Sharon to tell you more about how that all happened.
Thanks, Mike. So I'm trying to get my little mouse. There we go. Okay, so as Mike said, we all got together and we kind of talked about this, and we designed a study. And so the aims of the study were to describe the different types of PN prescriptions that required interventions in a large data set. Because obviously one day at a facility versus a long period of time at all the CAPS pharmacies can give us a larger data set. We wanted to correlate the pharmacist interventions with the various characteristics of the prescribing facilities. And then we wanted to go ahead and analyze these data to identify any site of care or population differences. Trying to get my slide to go. There we go. So this is a diagram of what the CAPS PN order entry process is. So obviously our different CAPS pharmacies work with the various institutions in designing what is best for them as far as order entry. We obviously encourage electronic health records with an interface with our system. So the facility goes ahead and designs their form, what they would like, and works with the pharmacy to do that with our pharmacies. And our pharmacists work with them, and then they set up the min-maxes within that system. So it could be a CAPS-related min-max, which are based on ASPEN guidelines for both macro and micronutrients, or they can use their own. And that's in particular to the neonatal facilities. They usually like a little higher calcium phosphate ratios. They look at solubility, the osmolarity, and then they do a clinical review. At that point, the hospital pharmacist approves or validates the order, and it crosses over to CAPS. That's the point where our CAPS pharmacists were involved with the study, and we identified interventions if necessary. And if the order is okay, it goes ahead and it gets approved and is put into the compounding system. And if not, the institution is contacted for change. So our very first study that we did was in 2015, and it was done at two of our pharmacies in CAPS Denver and CAPS Kansas City. And we did a 30-day study, and we received over 8,000 PN orders. And we identified 65 interventions. So as Mike has already said, Gordon Sachs' intervention rate was 1.6%. Well, ours was 0.6%, so a little lower. And it makes sense because we weren't looking at administration. We were only looking at transcription and then compounding errors. But what was interesting is that 70% of those orders that required an intervention ended up being changed, meaning our pharmacist contacted the facility and made a recommendation, and the facility went along with it. And that was related to neonatal, so mostly calcium phosphate issues. And that study led to the need for the larger multi-site trial, which we did. So in 2016, we got together with ASPEN and we created a work group. It was comprised of the PN Safety Committee members, of which 3 of my colleagues are on with me today, as well as Dr. Peggy Gunter. As Mike or Joe said earlier with CAPS, it not only involved myself, Todd Jones, and Dave Banco, but it also involved all of our 503A pharmacies, the director of pharmacies, and all of those pharmacists. So it was quite a large group. We did submit our proposal to be reviewed by the University of Michigan IRB, and our inclusion criteria was CAPS customers that had PN prescriptions and that agreed to participate in the study. We needed their permission to share their data. And the exclusion was those that did not agree to participate. So we got together, and the first thing that we talked about was we want to know more about the customers. You know, what's their site? Are they a hospital? Are they an LTAC, long-term acute care, home care? So we wanted to know the characteristics of that facility. Do they have a nutrition support team? Who's writing the order? Is it a physician, a PA, a pharmacist? And is there a clinical person that is reviewing the order prior to submission to CAPS? So we had those general questions listed on the customer survey. The customer identification was kept confidential only with CAPS. Each of the customer was assigned a study number, and that was also known only to CAPS. And then I went on with our team of ASPEN and CAPS to develop an intervention tool. And these are some of the highlights of the data collection tool. We wanted to know the customer type, the hospital, home care, et cetera, the patient age group, whether they were adult, pediatric, or neonate. And what was interesting for us, is it a 2-in-1 or a 3-in-1 formulation? And are the electrolytes ordered as ions or salts? And some examples of errors that we were tracking, you can see there: calcium phosphate incompatibility, osmolarity issues, and then we were looking at extremes, high or low within the macro and the micronutrients and the drug additives. You'd be amazed what people try and add to a TPN. So our pharmacists were trained. I set up a webinar and I trained all of the directors and the staff pharmacists on how to use the data collection tool and how to flag those items that required interventions, and ask them to give me little hints, kind of what, not just check a box, give me a little more details. As I said earlier, our high and low numbers were based on the ASPEN Safe Practice Guidelines. And then we did utilize that paper tool to capture all of those interventions. Our CAPS pharmacists reviewed every parental nutrition order received for a 1-month period in October of 2016. So once the forms were completed, they were sent to me, and I entered them in a secure electronic database along with a colleague of mine. And it was all aggregated and de-identified. So there was no identifying where it came from, who the patient was, anything like that. So what's interesting is we also de-identified the data for the customer survey as well. So we just have bulk data. It's not specific to individuals. And we shared that with the ASPEN staff. And then they hired a statistician to do all of the statistical analysis. And the chi-square test was used to conduct both the descriptive and the statistical analyses. So what's interesting is in that 30-day period, we received over 163,000 prescriptions. This is a huge data set. Of that, our customers, 23% of our total customers gave us permission to use their data, and we included them in the study. So that gave us the ability to utilize over 37,000 PN prescriptions. We're talking a huge number. And you can see there that most of them came from hospital, 97%, and then just smaller numbers were broken out between long-term acute care, regular long-term care, and 1% came from home care. So I'm now going to turn it over to Anne so that she can go through the actual results of the study with you.
Okay, sorry, I had it myself muted. We received a 23% response rate with the survey that we sent to all of the CAPS customers. And we had 80% of the responders agree to participate, and that translated into 232 individual customers. So a very, very large database of PM prescriptions and different customer types. Within the survey that we provided to and was completed by customers, we collected, like Sharon said, specific data regarding not only customer demographics, but also their parenteral nutrition processes. And this, we wanted to be very global and very broad in what we were asking, because this allowed us to assess real life practice and how it related to the ASPEN PN safety recommendations. And it also allowed us to assess the external validity of the study, since it was a national study. So over 3/4 of the customers included in the study were hospitals, with the LTACs being the second most common facility type. There was good representation regarding institutional bed size across the customers, with about 70% of all of the customers either at the 1 to 100 bed size or the 201 to 500 bed size. One of the things that we were really pleased to see also was that the customer geographic distribution was fairly even across the 4 defined regions of the country. So we felt like this was really going to give us some good information about all the different places within the US. Roughly 2/3 of the customers used CAPS-only compounded parenteral nutrition formulations, and 28% used a combination of CAPS compounded formulations and then multi-chamber bag PM products. And so in order to alleviate the extra the numbers and keep the numbers in line with what we were looking at, CAPS did not supply the multi-chamber bag products. And so the data from the use of these products were not included in the analysis. So this is clean data on PN prescriptions that were sent for CAPS compounding. The majority of PN prescriptions were ordered by physicians, and this was consistent amongst all or across all 3 age groups. So for the adult patients, the pediatric patients, and neonates. And when we dove a little bit deeper into the different age groups, as far as what types of prescribers were reported for the customers, in the adults and pediatric patients, the PN ordering and the second most common group was a mixture of clinicians. And then the third most common were pharmacists. For the neonate population, this was a little bit different, with some of the advanced practice providers such as nurse practitioners, clinical nurse specialists, and physician assistants being second as the ordering providers, followed by customers that had a mixture of clinicians. There was equal distribution between PN orders via CPOE and handwritten orders, and the majority of customers fell into the group of 0 to 5 PN prescriptions per day. And this also was consistent across all age groups. About 97% of customers reported having a dedicated clinician review PN orders prior to the transfer of those PN prescriptions to CAPS for compounding and dispensing. And so I want to note here that that's a very big number, but there still was 3% of customers without someone doing the review prior to transmission. 62% of customers reported having a formal nutrition support service. And when we looked at the minimum maximum limits for the PN components, half of the customers used the CAP specific min-max limits, which Sharon stated earlier were based on or are based on the ASPEN guidelines. And 32% of customers used a combination of the CAPS min-max and their own institutional min-max. And also, as Sharon said, this was mainly in the pediatric and probably more commonly the neonatal populations. So this is just a schematic kind of giving a review of the number of prescriptions and the processes that went in place. So like Sharon said, we had a little over 163,000 prescriptions that were received by CAPS during the study period. 37,634 were eligible for study inclusion based on the acceptance of consent. 23 that constituted 23% of the total PN prescriptions that CAPS received. And you can see that the majority of PN prescriptions were adult, followed by neonate, and then rounding the bottom were pediatrics. Now, if we take those 37,634 PN prescriptions that were within the study, 248 required intervention by a CAPS pharmacist. And so this was about 0.7% of included PN prescriptions. The vast majority were from hospitals, and the patient types remained the same, with the largest percentage being adult prescriptions, followed by neonate, and then rounding out the bottom with pediatric. And I want to say that as far as the PN prescriptions that required intervention, that was in about 25% of the customers that agreed to participate in the study. So about a quarter of them. Out of the 248 individual PM prescriptions, there were 252 interventions that were made. And the higher number of interventions was due to a small number of the prescriptions requiring more than one intervention. The top 3 intervention types included electrolyte dose clarification, calcium phosphate incompatibility, and amino acid dose clarification. Now, the biggest area where some of the institutions differed where it was predominantly in the calcium phosphate incompatibility limits. 94 of the interventions regarding this did not lead to a PM prescription change, and that was really due to those different institutional specific limits. Out of all of the customer demographic and practice characteristics, only the institutional bed size and number of PN orders daily proved to have significant difference in the need for intervention versus not. So things like facility type, geographical region, having a dedicated clinician review orders prior to transmission to CAPS, all of those other areas that we looked at from a customer, demographic and clinical practice type did not tie into a significant increase in the need for intervention. So 53 interventions led to a change in the PM prescription, and that was in a total of 47 parenteral nutrition orders, so about 19%. The patient type here was a little bit different. The majority were in neonatal prescriptions, so about 47%, so almost half. And next in line being adults, followed by pediatrics. The corrected interventions are listed there, and I will say that 80% of the interventions that led to changes in the prescription were related to the clarification of nutrients and insulin, as well as osmolarity limits for PPN. Of the 59 customers that require intervention, about 63% had a formal nutrition support service. And so if you're thinking back to what I reported earlier, this percentage is similar to the overall percentage of all customers having a nutrition support service. So regardless of whether they had an intervention or not, this number of the nutrition support service remained pretty constant. So it's a 63%. And one of the interesting findings was that a significantly greater intervention rate for customers with a formal nutrition support service was seen versus those without. And this was just shy of about a 3.5-fold increase. Now, the other interesting thing was that when you looked at the rate of PN prescription change, it was much more common in those interventions or those prescriptions that were written by a non-nutrition support service compared to a nutrition support service. So while the study was not designed to determine why this was the case, one possible explanation that we thought might have happened was that the nutrition support services may be handling higher acuity, more complex patients. And then the other may also be that the nutrition support service is an interdisciplinary service that may have higher level training and may be more comfortable with more out of the box PN management strategies. And so those are pure speculation, but seem to be very reasonable. And both of these reasons or potential rationales can lead to orders falling outside of the average patient min-max limits. And this requires an astute pharmacist with special knowledge and training to be able to question these prescriptions and reach out to those that are ordering them. So it brings into play that importance of the order review process. So why do we think that this study is so important? And we really, really do feel it is a very important piece of literature to PN safety. And one of the biggest things is that it's really one of the largest published data samples on PN interventions in order review and verification. And it represents a unique look at the PN order review and verification process, because this represents clinical intervention on a secondary review. Okay, so this is after it's been reviewed at the institution or at the customer's institution and then sent to CAPS. It is national and well-distributed data sample, so it's got great geographic representation, very equal. It has well-distributed patient type. It addresses a wide range of facilities. And we think it's very important to note that there was no significant difference in the need for intervention found based upon these factors, so geographical location or facility type. So we feel like the external validity of the trial is very good. And it also has and shows reproducibility, in that it had a very similar intervention rate compared to the CAPS pilot study. So that was around 0.7%, if you remember. So one of the things I also wanted to highlight, and that we highlighted in our paper, was an intervention that was made during the study period, which was similar to a 2020 ISMP report. And both centered around pediatric trace element dosing errors. The 2020 ISMP report was a 1,000-fold zinc overdose caught by a CAPS pharmacist in a pediatric patient. And the ordering error was that it was ordered in milligrams instead of micrograms. And the error was not caught at the institution during a two-pharmacist verification. And there was also noted that there was not a trigger in the institution's EHR. There was an alert at the CAPS pharmacist at verification, and there was an alert at compounding. And this was really due to seeing the volume and the abnormal volume that was required during compounding. And so the good thing here is that the pharmacist reached out to the prescriber and the zinc dose was corrected, and so it did not reach the patient. In the current study, and the one that we're talking about now, there was a 10-fold dosing error for zinc, copper, and selenium. And the alert was found at CAPS and allowed for crucial intervention and a PN prescription change. So, these both illustrate that even with multiple steps in place to prevent errors, there still is the potential and the need for someone who's skilled and knowledgeable to ensure patient safety and catch these. So what are some of the safe practices for PN? And this is really just a review. But the ASPEN PN safety recommendations, as both Mike and Sharon have shared, really foster standardized electronic PN orders, avoiding manual transcription within the PN orders, a standardized PN order process, as well as building, testing, and responding to warnings within the PN use process, and using double checks for order review and verification. And really the study, I feel like, since it is a secondary review, it really illustrates that the use of these alone do not eliminate the need for an independent review and verification of PN orders by a knowledgeable and skilled pharmacist. So it really relies on that last check. So in conclusion, the PN order review and verification is a crucial step in the PN process to reduce the potential for patient harm. And it really supports the need for institutions who do use parenteral nutrition within care to their patients to develop systems to comply with published PN safety recommendations, and also to include knowledgeable and skilled pharmacists to complete the order review and verification step. And so I'm going to end there and open the floor for questions.
Thanks very much, guys. Thanks for this presentation. Again, for those who have not seen this paper in Nutrition and Clinical Practice, I'd encourage you all to take a read through it. I believe it came out in December, but I think even in print, it'll be coming out this month or next month. And certainly if you're in attendance here and your pharmacist may not be, you'd want to pass it along to them as well. All right, so we do have a number of questions here from our virtual audience. Let's start with that a little bit. Maybe we'll go through, talk a little bit about the methods, questions maybe related to results, and then things having to do with the application, I guess, of this data. Interesting question here. Was there any discussion in designing this about eliminating controversial PN additives within CAPS? Suggested controversial additives like albumin and octreotide.
Yeah, that's a great question. Thank you for that. We did not discuss or get into detail about that level of detail. The focus was simply on, based on the processes that are in place now and what institutions are doing, what are the potential need for interventions and potential errors that are identified or avoided. And so we didn't dive into that. I think that, if there was a process in place and we also tried to address that, that could, potentially at least confounded the results for the purpose of what we wanted. That's an important point, though, and that's definitely a different potentially study, I think, as well. So I don't know, Sharon or Ann, if you would add anything to that, by all means.
Yeah, this is Sharon, and I agree with you, Mike. We didn't look at that, but we certainly have all of the data, and we can certainly go through there because there were some interesting additives that people wanted to put in. And I know albumin and octreotide are two of the ones that are added fairly frequently. So yes, it's an idea for another study. So stay tuned.
Perhaps along the same lines in terms of thinking about a secondary study, another study, think about how might you be able to capture the review that's occurring at a facility as well as the CAPS review. Sort of, I guess, question is trying to get a total picture of what happens in a review process in terms of errors.
Yep. Yeah, I think it would have to be a follow-up because we obviously didn't capture that detail, but I think we'd have to focus the questionnaire on that specific step. And it would be, questions like, do you have everything from the start of what training who does it, what training is received, what's the competency assessment look like? Do you have a standard checklist that they follow when they check? Is there a double check? What types of, and some of that could be the decision support and other technology that they have involved in that process. That's a great thought and a great question. But I think we'd have to spend some time and dig down to some very specifics to get an idea of what type of process that each institution would follow. So Sharon or Ann, if you'd like to add anything to that.
Sounds like
I was on mute. Sorry, go ahead. No, Mike answered it fine. Go ahead.
I was going to say, it sounds like he answered it fine, and it sounds like something maybe we got to think about moving forward with. Question, I guess this might be more for Sharon. Is there an ongoing protocol across all of CAPS facilities to capture errors and make interventions? Yes. Thanks, Joe, for asking that. It's a standard process that every order that comes in, once it's reviewed, if they've identified an intervention, it's logged. And we're actually working on an electronic spreadsheet right now that will be able to capture it. And then we can go back to individual customers. So it's definitely a daily process, and it's actually going to become even more, I want to say, I guess, defined to identify, to go back to the customer. Great. Good to know. In terms, I guess, of application of this question about what is the best strategic plan in a hospital to reduce errors in the PN processes?
Ooh, boy, we need a whole nother 45-minute session. It's a great question. No, you're absolutely right. That's the whole point. Like, what do we do? How do we take this and how do we make it better for patients? How do we make it safer? That's obviously certainly one of the things we want to try to do. I think, one place I would point folks to is the study by McKay that I described, because I think that was a nice description of what they did. It takes a lot of work and effort. I mean, you need support from multiple, all disciplines really. But they kind of went through and did kind of a systematic evaluation of their process, and then worked to identify their kind of points of concern, and apply ASPEN recommendations and best practices to improve their process. And they showed, I think their results speak for themselves. I think it was really great. And I think the other piece is, some of it is within your own institution. It's never a one size fits all. What types of patients do you see? What types of, clinicians do you have there? What types of expertise do you have? And where else can, what works best for you and what makes it safest, and there's options out there. Are you going to use the multi-chamber bags? And there may be good rationale to do that. And maybe that's the safest option. Are you going to compound in-house? Are you going to outsource? And I think each institution then has to consider their patient population as well as their in-house resources to decide what's ultimately best for them. But Sharon or Ann, I'd be curious if you have other things to add to that.
No, I think you covered it well. Since I'm not in an institution, I'm on the outside looking in. So I think those are some good ideas.
Yes,
oh, sorry, go ahead, Ann.
No, I was just going to say, I think Mike covered it well. There's a lot of different things to consider, and it's really taking a look inside at the institution. And
I think the one thing that makes it, this certainly to me, there's several things. Ann did a great job summarizing, but I think it notes that even in those institutions that had a nutrition support team, and they tended to push things more when they have different types of maybe expertise or patients they're caring for, the change rate on their interventions was not zero. And so even in that case, when you have arguably the most knowledgeable people involved, like there was a role for another independent review and verification and a safety check. And so I think that really highlights that, the processes, of course, are far from perfect, but that there is still value in that check, as regardless of the type of institution or expertise involved.
Very good. Last, we've got time, I guess, for another question or two. I think I know the answer to this one, but we're going to throw this out there. So who should be reviewing discharge PN orders? And also, along with that, presumably the goals of care for the patient, which I know aren't always associated with the discharge orders.
Well, I think in the in the ideal world, it would certainly be the prescription itself. Definitely, the pharmacist should do a final check, but I also think really, it should be the pharmacist with other members of the team as part of the, the discharge planning process, and then certainly a direct handoff to the home care company, whoever that may be. And I think that would be the ideal state. And I know the reality, of course, is we're all strained for time and resources, and slightly different processes and many other challenges. But in the ideal world, I think that certainly a review of the order, as kind of described the process here, that skilled, that knowledgeable pharmacist is an essential sort of final check for sure. But even before that step, I think as you're planning, it really has to involve the pharmacist with all members of the team.
Very good. And this question probably follow up to that, and anybody can answer this one. So how could we then encourage increased involvement of pharmacists at the customer hospital or LTAC, et cetera, especially neonatal, because it seems a lot of errors happen there.
Yeah. Another great question. You're absolutely right. We struggle with this, and I know for the pharmacists out there, if you didn't have a chance to attend the pharmacy practice section meeting, there was a good discussion about, really even starting with the first step, but how do we improve education on this, even in like pharmacy curricula, but for other disciplines as well. I mean, I think it's, it really is a team approach. Ultimately, you need to get the pharmacists involved, but I think it's, sometimes depending on the situation, it can be difficult. You may have one discipline that is, for whatever reason, constrained by resources, or depending on what your process is, and it can be hard to engage those other folks. And I think it's, you find your allies where you can, and try to build momentum behind it. And really, I think if it's any one individual or one department sort of saying, well, we need this or I need that, I think it's less likely to succeed. I think it's, sometimes it has to be a grassroots effort depending on what your practice looks like currently. But I think it's, you focus, ASPEN has great resources as well to kind of emphasize, and I hope this study contributes to that, of there is still a need, even in some of those places that might consider they have some of the best practices in place, right? It is a complex, high risk process, and there is still a need for intervention, for careful review of these orders. And so I think that's, try to emphasize that and use the data and what resources are out there to make a compelling case. And then you have to keep at it. It takes time and persistence. I say that and make it sound easy. There is no way, shape, or form is it easy. At least I know that. So I don't know, Sharon or Ann, if you want to add to that.
No, I agree with you, Mike. I mean, I think it needs to start in the schools. One of the things that we try and do at CAPS is I have a PN training program that I try and help customers, particularly like the long-term care and the long-term acute care pharmacies. I go in and try and help them learn how to do TPN and how to monitor, because the monitoring once they're discharged is crucial. They shouldn't stay on the same thing forever. So I think that is helpful, but I do find that they're terrified, absolutely terrified of having to deal with electrolytes, much less parenteral nutrition. So if we can get the schools on board again, that would be huge.
I 100% agree.
Thanks.
And that's an effort that we're all going to have to take on, is maintaining that topic and that educational stance within the colleges, and also bringing that into residency training and institutional training programs.
I think we're all in agreement with that. That's great. Well, that we went over a couple of minutes, brings us to the close here. I wanted to, again to thank Ann and Mike and Sharon for putting this together, and CAPS for helping support the study and having this presentation for all of us. Of course, thanks again to all of you for joining us today. Hope you enjoy the rest of the meeting. Thanks again.